I did, in talking to Anil, expand this talk a little bit to sort of better bridge the gap between the knee course and then the more arthroplasty heavy course. So I will talk about what Amar was just speaking about, but I think I broadened it to really how a deformity specialist can be an ally to an arthroplasty surgeon's practice, and how, you know, we should be on speed dial along with the infectious disease doctor, you know, and a select few, and the plastic surgeon. So with that, I'll get started. You know, so the goal of arthroplasty is really to put in a perfect joint, you know, every time. You want to go into the OR and you want to leave knowing that you achieve perfect alignment. And, you know, when you have normal anatomy, that's relatively easy to achieve, you know, when you're a high volume surgeon. But that's not always feasible when you have bones that have deformity pre-op, and rushing into an arthroplasty is going to get you into trouble, and really you should step back, analyze your deformity, and ask yourself, is this person ready for an arthroplasty? You know, so here's a person, obvious bone deformity. Yes, the hip, you know, was probably dislocated, never formed, you know, needs a hip replacement, but is that really a good idea right away? So call a friend in these situations. So as a deformity specialist, when I'm talking with my arthroplasty colleagues, I'm helping them correct extra-articular alignment prior to arthroplasty, correcting length and rotation ahead of arthroplasty, since, you know, doing a total knee is not the place you want to be, you know, correcting a lot of length or rotation in that limb. Post-operatively, I'm going to try to prevent early revision. If there's other deformities, I can still correct, restore limb length. And then we'll get into what Amar mentioned, you know, what happens when the knee is failed and needs to come out. Are we doing a knee arthrodesis with a true fusion? Are we going to do more of like a pseudo fusion with an antibiotic spacer? And then kind of the next frontier, I think, is osseointegration limb reconstruction in those patients who, you know, the above knee amputation is the treatment. So first we'll start with correcting extra-articular deformity. So I'll go back to that case that I just showed. You know, this person both has valgus as well as a large progrobottom deformity. Both of those are going to need to be corrected, you know, and you know, there's going to be a hip stem in there shortly. But I want to correct this deformity with an intramedullary nail. So really I need to talk to my colleague and say, I really need to go first in this situation. Otherwise, you're really going to limit my ability to correct this. Usually this pattern of deformity will also have a lot of external rotation or retroversion of the femur. This case did not happen to have that, but in general, that's going to be needed as well when I'm assessing these deformities. So relatively simple deformity correction, was able to do this with one osteotomy. You kind of bridge the difference between where the apex of your deformity is in both the sagittal and the coronal plane. The only one that makes this a little bit unique is, you know, you do want to use blocking screws whenever you're using intramedullary nails to try to, you know, get the correction that you set out to achieve. You know, those heal pretty well. This was, I think, about 9 months later that I was able to remove the nail, and then, you know, my colleague comes in and does the arthroplasty that the patient really desired up front. This looks like, you know, really, you know, a patient who was being evaluated by a colleague for a total knee arthroplasty, but more and more of our surgeons are getting standing x-rays as part of the preoperative evaluation. Noticed that there was a leg length discrepancy in this patient, and then when I evaluated this patient, I also noted that there appeared to be aneversion of the femur, which was about 32 degrees, which you would argue is about 15 degrees more than normal. So prior to the total knee, you know, we can do a deformity correction. And so I'm going to shorten the femur, I'm going to rotate it, and then am I going to correct the valgus? This question just came up as part of our panel. In this case, I'm not going to. If this person's planning for a total knee, I'm going to say a lot of this deformity is coming from intra-articularly. There's also the MPTA of the tibia is greater than normal, but that can be compensated for with a bone cut during the arthroplasty. So I'm going to ignore the valgus for now in this patient and just worry about the rotation and the shortening. So I used a lengthening nail here in compression mode. I found this is to be shortenings were at high risk for non-union. My partners also feel this way, so we've all kind of converted to doing this with compression nails. You can see once you do the rotation, the shortening, how robust the callus is that you can get with these compression nails. You know, this person, you know, is a 65-year-old patient. You're not expecting them to necessarily have robust bone healing, but when you apply the appropriate forces, you can be surprised. 1 year later, I can actually show you the total knee arthroplasty because just based on this deformity correction, shortening that leg really offloaded her knee. She still hasn't had a total knee. And then, this is a patient who, again, 62, has kind of had neglected multiple hereditary exostosis. You can see valgus both at the knees and the ankles. Severe pain with angulation, and was initially seen by an arthroplasty colleague. But when you look at what that's going to require, this is mechanical access planning. This requires some pretty large bone cuts, especially along the tibia. And you're going to ask yourself, well, is this a situation where I'm going to have to put in a primary hinge? Do I want to put a primary hinge in this patient bilaterally? Sagittal plane, similar scenario. Going to be a large bone cut there, removing a lot. So what else can we do ahead of time? So I chose to correct the deformity in this patient to set him up for an easier total knee down the line, maybe using primary components instead of a hinge. So here's what it looked like after the osteotomy on the left and right, and then here in the middle I'm showing what it looks like after the valgus and procurvatum correction. Certainly he's going to feel even much better after this and make the total knee easier. And if you really zoom in, I just said how much bone you'd have to remove to do the arthroplasty. When you do the deformity correction first, you gain a lot of bone. So, between the yellow lines, this is all going to be new bone that you can use. And so, if you're going to have, if you can use primary components, great. If you have to stem the tibia, you have that much more room. Same thing on the sagittal plane. You've gained a lot of bone here. This, is going to help this patient down the line if they need, revisions down the line. People with MHE tend to form bone really well. You can see this was about 6 months later, healed really well. And he also has 6 months later not undergone his TKA, although I assume this patient will. What about after a total knee replacement? Can you still correct deformity without doing a revision? This was a patient who about 15 years ago had their deformity corrected. The knee still went on to have bone-on-bone arthritis. Went to another institution to get their total knee done. The knee was put in really without respect to the mechanical axis and only respected the corrected anatomic axis. And as a result of that, the knee was in significant varus, which you can see here. So that amount of varus was also leading to a leg length discrepancy. Overall about 13 degrees of mechanical axis malalignment, and a 2 centimeter leg length discrepancy. Very unhappy. So the question is, do you revise this knee? Do you say, oh, the knee was the problem, let's take it out and put in a better one? It's well fixed at this point, and this was relatively recently, so she has very mild laxity. Her answer was no. The reason she was sent to me was that she did not want a revision. She thought that was, silly if her knee was functioning well. So could there be a deformity correction? So I executed an opening wedge distal femur osteotomy using some patient-specific instrumentation. I used an opening wedge because that does restore some of that LOD. When we were talking about opening versus closing wedge earlier, I think one thing is when you get these standing x-rays, you have to assess what their leg lengths are. If you do a closing wedge on a leg that's already a little bit short, you're going to set that patient up for an over centimeter leg length discrepancy, and they're not going to be happy. So here I used iliac crest autograft. That's pretty uncommon. This patient was in her 70s, so doing an opening wedge was already a little bit risky. And then I built some additional support into that plate. But the deformity correction was excellent. You can see there, pretty much restored mechanical axis and leg length discrepancy, and then she went on to get a solid fusion. One of those screws did back out, but did not bother her. So here we have after total hip replacement. This was a congenitally dislocated hip that was untreated from another country. So she undergoes total hip with a shortening osteotomy, well done hip replacement. But then you can see here she's standing on a 3 centimeter block, has some significant leg length discrepancies she needs corrected along with valgus. So the lengthening nails have come a long way. They're now, you can have shorter ones which fit below these hip stems. So you want to template these cases, make sure you have your right nail length, your right osteotomy location. You're going to need to use blocking screws both for the deformity correction and to not induce deformity when you lengthen, and you have the appropriate starting point. So you can see the execution of that based on the planning. You go in with a plan so you don't plan to fail. And then so you're going to lengthen her until she's standing even on that standing x-ray, and then you're going to allow full weight bearing once 3 cortices have bridged. This is the beauty of distraction osteogenesis. The bone heals very well. She was extremely happy with this result. These magnetic nails do need to be removed at about 1 year. Same thing post-TKA, 36-year-old male. His knee is painful, feels unstable. He's got a flexion contracture. You can see it looks like the distal femur replacement there has pistoned up into the femoral diaphysis. You know, a CT scan confirmed that. Had a negative aspiration for infection. Whoops. I know I'm going to have to revise the femur first, but I want to gain length afterwards, so I'm going to keep my stem short. I'm going to use a cone and a collar for bone ingrowth. Maintained the tibia in this situation because I didn't want to remove bone in a younger gentleman. Then I was able to squeeze this lengthening nail above that stem, and then you can see 6 months later we restored about 2.5 centimeters of length that he had lost when that distal femur had subsided in the metaphysis. Now getting to what this talk was initially going to be on, you know, when sometimes the TKA is unsalvageable, you have a recurrent infection, a severe problem with the extensor mechanism, maybe massive aseptic loosening. This was classically, you know, the answer was knee fusion. And sometimes that fusion is really more like a long-term antibiotic spacer because obtaining bone contact is very difficult. So here's a case of bone-to-bone knee fusion. 60-year-old male, had a history of a kidney and liver transplant. He's on some pretty serious immunosuppression. And then he also, on top of that, now has a chronic draining sinus from his total knee. Classic signs, periprosthetic osteolysis of both the femur and the tibia. Cultured out multibacterial. So had a long discussion. This was not a patient who you want to be taking to the OR many times. Each time, you know, he gets 1 2-stage, which fails, he gets another 2-stage. You know, this is very hard to take these transplant patients to the OR, requires a lot of preoperative work. So how can we make this patient's life simpler with fewer operations? Remove the knee, put on a long leg fixator to then, you know, you have to compress the distance because sometimes you can't get that acutely. This was right after the OR. You can see the alignment's not quite perfect, but using the hexapod, I can correct my bone surfaces. I can dial in that amount of flexion that I want as part of the knee fusions, let the tissues settle down for 8 to 12 weeks while they get antibiotics, start the compression, and then when everything's looking good, I can convert him to a long nail and quickly transition to weight bearing. This is a durable reconstruction, and he had no infection recurrence. Was very happy he chose this. And then sometimes we call this, you know, I get consulted by one of my colleagues for a knee fusion, and this is actually the more common situation. You know, they've done many attempts to salvage a knee. Here's how it looked. It has a recurrent infection. Now the cement mantle's broken. You know, there's clearly osteolysis around the implant. So it needs to come out. The problem is these are usually older hosts. They're in their 70s and 80s. And if you want to try to get a true bone-to-bone fusion, you're either going to have to do a massive shortening, which is cosmetically going to leave you with a very abnormal leg, or you're going to require a bone transport, which really none of these patients are going to opt for because that's a, you know, at least a year-long process. You hope that they, you know, can even make that amount of bone. So what is more commonly done is they end up with some sort of long-term spacer. Again, chose to use a long nail in a lot of these situations with just an antibiotic cement in between. This is a good way to usually maintain them without infection. You can see this, I've done this a number of times. They can ambulate on this construct, sometimes with no pain, sometimes with minimal pain. But I will say that the one issue is femoral neck fractures, especially in some of these older hosts. They don't have good bone quality anymore, and they can end up with this, which is not the phone call that I like to get, because it means I'm going back to the OR, more surgery, etc. And then as we all know, if you do enough knees, some of them, you know, an above knee amputation potentially makes more sense. If you have infection, your extensor mechanism doesn't work, you know, it's a very difficult leg. But I think there's more hope for these patients than there have been in the past. Classically, they've needed a socket prosthetic, which is very hard to wear on an above knee, you know, amputation residual limb. You can get wounds, you get a lot of dermatitis when you wear sockets, a variety of skin infections can develop, pain is very common, sweating, perspiration, change in the residuum, and often this just leads, especially above the knee, disuse of the prosthetic entirely. They're going to be using crutches. It's very difficult to fit some of these at all with the prosthetic. So with osseointegration, we use a bone-anchored prosthesis that's intramedullary within the femur. It's textured titanium, which provides a strong bond to the bone, and this comes out through a permanent transcutaneous aperture, which you can see here. You really want the skin to be as close to the bone as possible so that it's really not moving. This is going to keep the skin quiet and help prevent your infection. But the ability of these people to ambulate versus a socket is pretty incredible. They increase their prosthetic wear time, they're more mobile, their functional scores on pretty much any exam you give them are going to be higher, they're going to use less oxygen consumption, and then overall they're just going to have a higher quality of life versus wearing a socket. You can get some osteoperception through the skeleton so that this patient can feel that she's walking on sand and can do it safely. This is really a paradigm shift for our above-knee amputees. On the left, you can see a bilateral. This is a wounded warrior, obviously not a post-arthroplasty patient. There is an infection risk that exists. Superficial infections around that aperture are common, usually just treated with oral antibiotics. Deep infection has thankfully been uncommon and is why this technology exists. We tell patients about 10% at 15 years, although this data is still being developed. And right now, I think if you're in this field, you would say that the functional benefits and the quality of life that these patients have outweighs the risks. So I could talk about osseointegration all day, but I think I'm very much out of time, so thank you for your attention.